Hello, I'm Chuck Appleby, Director of Publications for the Scottsdale Institute. Welcome to Scottsdale Institute's Take 5, our video interview series that's part of our coverage of SI members' response, recovery, and reimagine during the COVID-19 pandemic. Today, we're taking time to take 5 minutes with Robert Eardley, who's CIO at University Hospitals Cleveland. Welcome, Robert.
Thank you, and thanks for having me.
Thanks for joining us today. In a recent Scottsdale Institute Inside Edge report, we tackled the issue of the convergence of IT and operations. And you mentioned that University Hospitals is continuing its IT function, a traditional IT function of run, maintain, and modify, while you're also pursuing, innovative new projects and initiatives. So how, Robert, has the COVID-19 pandemic accelerated this convergence? And how do you see that playing out in the post-COVID health system?
Yeah, well, thanks, Chuck, for the question. And for us here at University Hospitals, as this pandemic developed early on, I view that we are really part of operations. IT supports operations, and so maybe just I'll give you a list of some things that we did as part of what I categorize as run, and then I'll give you a list of some things that I'll categorize as new or innovation. So from a run perspective, how do we run our systems? How do we modify our systems really on behalf of the operational departments? Some items that would be on that list early on, we moved to support the work from home initiative, which took advantage of the fact that we already had two-step login or dual factor authentication into all of our systems. So we were well prepared for that, but we had to virtualize a call center. So we have hundreds of agents typically in our call center, taking calls for patient directions, for billing concerns, for scheduling. And so we had to move to really support our operational partner who's in patient access and in customer billing to virtualize that staff of 100. So deploying laptops, having them understand how they log in remotely so that our operational partner can run their business well. I think as many of you watched the development, we were intimately involved in building the surge bed capacity. Now, we were partners to our operations group really under our unified command at that point to be able to build the capacity, which really was clinically, equipment-wise, resource-wise. So what we were doing in IT was merely building out the capacity from our IT systems to be able to keep up with the resourcing and logistic discussions that were happening by our clinical partners. Another example of keeping up with our operational partners is really around telehealth. Now, for quite a while, we've had a partner in MD Live, but what we did creatively or uniquely in this the early weeks of this pandemic is we used our typical systems. We have a Cerner Sorian for registration, and then we use an Allscripts TouchWorks to document clinically. We modified our workflows within our Sorian product and within our TouchWorks product so that the physician from home could be conducting a virtual visit, and they would document in TouchWorks the same way as they always do. And then they would add a modifier that would then allow for the billing side to bill for that, given the quickly changing billing parameters for virtual visits. So it wasn't IT really leading, but we were there partnered with our operations in order to allow our physician services to conduct virtual visits on the same systems that they conducted physical visits the month prior. As you might imagine, there was plenty of work with medication, laboratory routing, and so we really were enabling the clinical workflow changes for our laboratory partners, our pathology chair, who, on behalf of Unified Command, was keeping up with all of those testing changes that I'm sure all of us followed as this went out. And then I will finish that kind of category of the run side of what we do with adjustments to our Oracle system, which is our ERP, or Enterprise Resource Planning, payroll, and the like. We had to make changes to employees' pay, to the hours that we could work during this time, adjustments to our contributions to 403B, for instance. So this was a system we've been running for a long time. We were downstream from really letting this play out by our Unified Command, our HR partners. What were the choices we were making? And then we had to make a lot of adjustments to our Oracle system in order to enable that. So let me pause there before I go into some of the new items that we've been working on.
That's great, Robert. Thank you. That's a rich snapshot you've given us of the your traditional run, maintain, modify function, which sounds like borders on innovation to me. So go ahead with what your new initiatives are.
Yeah, so new might be more new solutions for us. And so we, under our Chief Clinical Transformation Officer, we deployed a remote patient monitoring system. So if a patient presents in our ED and we don't have a need to admit them, but we do want to watch their vital signs, their oxygen saturation, we quickly deployed the product called Massimo. And so it goes home with the patient, connects wireless and cellular back to a physician dashboard that has all of our remote monitored patients on that. And we did have an incident where a patient had deteriorating signs and was actively called, and then navigated to the ED for follow-up care. Right now, we're looking at 2 products in the new category for what's called virtual waiting room. So we don't want to have patients physically waiting in chairs. And so they're going to get a text, typical use cases in their car when the organization is clinically ready to see them, so they can go either from their car or from maybe waiting outside right in to the clinical area without having to wait in the waiting room. So we're looking at 2 products. The ones we have to be looking at is Patient Track and Navimize, but there's many. We've shifted to WebEx Cloud. We've run on-site WebEx for a long time. And so that reached our capacity of 800 for us. And so we've lived on that for about 10 years, but this shift has run out our capacity for our on-site. So we have a new agreement with Cisco. And then I'll end with the e-visits. So e-visits are this form-based asynchronous where you type in what your concerns are and somebody from the clinical practice writes back a response later. That was a feature that we had not enabled yet in our organization. We've enabled video visits, but not e-visits as a kind of a form-based interchange. And so we worked with a partner to be able to gain a solution, and we're in the process of piloting that out now with our physician offices. So that's a quick recap of some of the new things that we've been involved in.
Thank you, Robert, for sharing, as I said, that rich snapshot of university hospitals' IT strategy during the COVID-19 crisis. And we look forward to continuing our conversation with you and other executives at our SI Summer Panel Series. And for more information on how SI member health systems are driving innovation during this historic time, please visit SI's extensive COVID-19 teleconferences and other resources on our website at SI COVID-19. And thanks for taking time to take 5